So I want to welcome you all today to the 2021 CHSPR conference, which is virtual, as you can tell, and it's all about integrated care. So I want to first thank our sponsors for making this conference possible. So that includes the BC Patient Safety and Quality Council, the BC Ministry of Health, the BC Academic Health Science Network, the Canadian Institute for Health Information, the Michael Smith Foundation for Health Research and Healthcare Excellence Canada, and which is the brand newly amalgamated organization that brings together the Canadian Foundation for Healthcare Improvement and the Canadian Patient Safety Institute. I would like to talk to you today about the themes. So today we're going to open up the conference and talk a little bit about what integrated care is and why it's been so challenging. And then tomorrow we're going to focus more on some solutions. I'd like you to engage with us via Slido during the Q&A period that follows, and you can use a code which is hashtag CHSPR 2021 for the Slido, and you can get that on your phone or have it available on a different screen. If you have a technical issue, you can contact us using the Zoom chat feature. I would also encourage you to engage on Twitter using the hashtag CHSPR 2021. And so I would like to acknowledge that we are fortunate to meet virtually today from the traditional territories of Indigenous peoples from across Canada. I am on the unceded territory of the Coast Salish peoples, and it is my pleasure to introduce Coast Salish Elder Roberta Price to welcome everyone to our conference. So Roberta, I'll turn it over to you. Thank you.
Thank you so much, Sabrina. Just gonna put my cedar headband on. Pick up my sacred cedar boughs and my sweet grass, and I'll start us off in a good and respectful way. Thank you, everyone. Haichka Siem Siaya. Greetings and welcome, everyone. As Coast Salish matriarch and elder, I wish to give a very warm thank you to all my relatives on the Musqueam, the Squamish, and the Tsleil-Waututh for welcoming me to live in the unceded lands of my relatives, Musqueam, here in Richmond for 41 years now. As Coast Salish matriarch and elder, I wish to give each and every one a very warm welcome who live, work, and play, give and receive service on our unceded, ancestral, and occupied lands of my relatives, Musqueam, Squamish, Tsleil-Waututh. And as Sabrina mentioned, wherever you may be across this wide virtual circle here on our Zoom meeting today, give time out of your day, your week, your month to give reflection and give honor and thanks to all the ancestors of the lands on which you live, work, and play on. Thank you so much, everyone. Always holding my hands up in thanks and honor to my beautiful mentor teaching elders, Elder Vince Stogan from Musqueam, Elder Bob George from the Tsleil-Waututh. All their teachings, whenever we come together, we share a blessing and a prayer for our time together. So I'll start us off in a good way in that respect. Osiam, thank you, everyone. Haichka Osiam, Osiam. We give you many, many thanks, Creator, for bringing us all together in this very wide virtual circle in such a warm and respectful way. We ask, Creator, that you bring your blessings down upon our minds, our hearts, our bodies, our spirits. So when we think our thoughts, they are good, positive, and respectful. When we speak our words, they are good, positive, and respectful. We call upon you, Creator, to bless the food and drink we put in to nourish our bodies on our journeys to wellness and strength. We give you kind thanks each and every day, Creator, for the special blessings of protection you bring down upon all the beautiful people who are working so very hard on the front lines during this pandemic, for all illnesses, and especially for our ongoing opioid crisis. Continue to bless and protect them and their families, Creator. We kindly and respectfully ask you, Creator, to wrap each and every one of us in your warmest blanket of protection as we journey through this part of the journey of our lives together. Help us all to keep safe in our travels, both near and far, Creator. We always give you many, many thanks, Creator, as we ask you to bring all of your blessings down upon all the ones that are hurting, all the ones that are hungry, all the ones without homes, and especially, Creator, all the ones that are hurting. Haichka, Haichka Ocean, Ocean. Thank you so much, everyone. I'll pass the cedar boughs back onto you, Sabrina. OCM, OCM. Thank you.
Thank you, Roberta. And we're really looking forward to also hearing from you in the next session. But thank you so much. It's such an honor and a privilege to have you formally open this conference. I really missed seeing you, and I'm glad that you're here. So thank you. I'm going to turn it over now to the first session chair, Dr. Jason Sutherland, who is a faculty member at the Center for Health Services and Policy Research, to introduce our first speaker.
Good morning, everyone. My name is Jason Sutherland. As Dr. Wong said, I'm a professor in the Center for Health Services and Policy Research, and I'd like to welcome everyone to this morning's session and gratefully acknowledge that they are making time out of their day. I'd like to start by acknowledging that we are sitting, or I am sitting, on the unceded territories of the Coast Salish people and the Musqueam peoples here in Vancouver. And I'd like to start off by outlining the opening session of today's conference, and that is we're going to be starting off with a talk by Dr. P.G. Foray, who's the Director of School of Public Policy at the University of Calgary. Following Dr. Foray's talk, we'll be having two respondents responding to what they've heard from Dr. Foray. The first will be Elder Roberta Price, who you just heard from, and also Tess Romain, who is the CEO of the Toronto Central LHIN, pardon me. So with that, I will hand it over to Dr. Foray.
Good morning. Can I see my slides? Yeah, please. Yeah, thank you so much. Yeah, good morning. I'm very honored, very pleased to be here. I think my last day in Vancouver was for the 2019 conference, which means, yeah, already 2 years ago. Very honored, very scared as well, because, you know, I think that in this virtual room this morning, I can't see anybody, but I am told there is a virtual room full of very knowledgeable people, and I'm pretty certain a lot of you would be much better placed than I am to do this opening talk. I try to understand at some point why I've been invited in the first place, and I think in large part, and it explains this idea of a policy perspective, is because I'm not so much an end user of the research that is performed on integrated care, but I'm certainly a gatekeeper. I spend most of my career, most of my work is done developing and implementing policies, and in large part, I do that based on the evidence that I'm able to gather, and in that sense, I'm truly a gatekeeper, and what I will present this morning is my own limited understanding of where we stand at this moment. I call the talk as well, I mentioned here the pull of gravity, and this is because I gave many talks throughout the years where I try to explain why it is so difficult to bring change in healthcare, why it is so difficult to counter the pull of gravity in our sector, in our field. You know, 2 weeks ago, I was serving on a peer review panel in the East, and we're looking at projects and proposals and just making decisions on grants and scholarships. And it was striking for me. I was thinking of this conference that there was, you know, I've been saying projects and proposal, talking about nurse practitioners and talking about teamwork and talking about integrated care, as a matter of fact, probably for 30 years. We are at this moment the third cohort of people doing research on this topic. So, why it is taking so much time. And this is my first question. The reason success is not warranted in health reform, the reasons are many. I mentioned here a few that for me are more important, and of course that in my opinion are directly related to the theme of this year conference. The first reason, and many of my colleagues have worked on this is the problem is that we have to prove when we introduce change that it will bring clear benefit, perceived benefits for patients and providers. And finally, so few of what we do or what is implemented in the end is bringing true and clear benefits. And I'm not saying integrated care is not bringing those kind of benefits, but we have to ask ourselves the question. We know, for instance, that structural integration, we have tried that again. Very often doesn't change anything but the letterhead, and so or the acronyms that patients and providers have to use. And this is clearly one of the issues we're facing. We're facing a problem when options and models proliferate. The message, the overall message to decision makers is sometimes confused by the number of options and models. I don't know if you have done the experiment of looking at, I did that in preparation for the talk this morning. You spend a day or two looking at papers that have been published that are trying to provide you with the definition and a sense of where integrated care is going at this time. And you're finding an incredible number of models for sure, but you're also noting that a large number of the papers themselves are just typologies. And this is never a good sign in a given field if most of the papers are basically typologies. You have, of course, a lot of papers that are research papers talking about different experiments and studies, but the bulk of the paper that have as the goal to define integrated care are typologies. And I could answer questions after why this is a problem, but it certainly creates problems for people that have to make decisions. We have a problem of confusing incentives. This is not new in our field. Incentives that are very often sending the signal that we want more services, but not necessarily more care. And incentives also that are not only financial, that are related to career management, that are related to working conditions, that are related to the satisfaction of providers, whoever they are. And again, aligning incentives is a extremely important issue when you want to introduce change. We're facing, of course, competing needs and priorities. This is true of every attempt to change anything in health. Very often I have the impression that the core of the problem here is the ratio between primary care and specialist care. And the fact that most of the work on integrated care is insisting, and properly insisting, on the need to change that ratio and to change it to the benefit of primary care. Well, so many of the needs and priorities that are expressed and then that are translated in policy decisions and are related on the opposite to access to technology, access to new type of treatments, and access, of course, to acute care. And finally, something that you learned along the way is that politics is always trumping policy. And so even if you have built the best possible policy, you have drafted the perfect solution, in the end, what will be needed is some sort of leadership and understanding on the part of the politicians, the real decision makers, that this makes sense. And I have heard so many times people telling me that you cannot win, for instance, an election on healthcare. I asked myself the question, what will be when you look at places where this has worked, where you could say with a certain degree of certainty that you're facing an experiment that has been sustained, that has produced the type of results we're looking for in terms of quality of care, in terms of patient experience, in terms of provider satisfaction, as I mentioned. You're most of the time are finding those conditions, those principles as part of the experiment. Of course, a taste and an openness to innovation that is not a given in our system for reason you know as much as I do. Some sort of opening to the capacity to experiment, and I have heard many times the idea that Monique Bégin expressed first, you know, that Canada is the country of pilot projects. But the problem is not so much that we are doing those experiments. The problem is not so much that we are doing those pilots. The problem is that the pilots are designed all the time not to fail, and therefore that we are not really experimenting. And I think there is a lot of thinking to be made about the way we develop and we fund and we support experimentation in our system. Competition doesn't really exist in our system. It is an issue. I think a lot of the innovation we're seeing coming from countries that we try to emulate is generated by the existence of some sort of competition. Difficult to establish in our system, but I still believe it will be a great thing if some sort of policy learning is taking place. The thing I have heard probably the most in Canada since I started working in health policy has been the idea that when you mention that a given province have been able to do something, the other province will immediately react, oh yes, but things are so different here, you know, we cannot do the same. And this of course doesn't help for transformation and change. I mentioned at the beginning this idea that we are the third cohort of people working on this issue, but I think the difference we're seeing now is that most of the proposal I have seen are heavily informed, and this is right by data, by a conscious of the need of precise measurement of what we are trying to achieve. I think this is a progress, and the counterpart of measurement is of course transparency. My hope is that transparency will not be only for pilots. My hope is that transparency will not be only for changes for what we try to introduce in the system, but that transparency will also be there to show us what are the important places where we still see unsafe care, duplicative care, where we're seeing competing care taking place, and as again the idea is that the other side of the data coin, the measurement coin, should be transparency, open to all to see what is happening. Let's go. Let's dive a little deeper in what we could learn when we look at the experiments, at the transformation, at the projects that have actually been implemented, and the problems that are still present in terms of understanding. Again, it's my naive take on this when I look at it and I try to understand what are we trying to do. The first thing that for me it's extremely striking is that we speak of integrated care, but it's never very clear until you have read the first two paragraphs of the paper what exactly we are trying to integrate and the basis on which this integration is taking place. I see projects that are essentially trying to integrate people on the basis of the type of patients or clients that are the object of the project, and I'm thinking here, I'm sorry, of a project that are intended, for instance, to elderly or to patients that have very defined social demographic characteristics. We're seeing project where, in fact, we're trying to integrate people on the basis of their health condition, COPD and cancer, and I have one of my students doing a very interesting project now on chronic kidney disease in Edmonton. People that have proposed integration on the basis of roster of patients or territory. More and more projects that are trying to address the problem of vulnerable and racialized people, and so people that are defined by precise cultural or social characteristics. And of course, this is very dominant in the US, the idea that finally we are just integrating people on the basis of who is paying for their care. And all this is good. I have no particular bias in favor of an approach versus another, but it creates a lot of confusion when people are trying to understand exactly what we try to achieve. Second point of where I see questions and issues is understanding who should decide. Who should decide about the care that is provided? Who should decide about the breadth of what will be covered? And here again, the impression you get from the literature is very often that, well, basically all the people that are identified on this slide are asked to decide for at a point or another. It's certainly good. I'm all in favor of patients, of clinicians, it's a good idea to have panels of multidisciplinary panels making decision. In some instances, it makes a lot of sense to have the provider organization or the health authority to be making decisions. The problem it creates is really a sense that the problem is not so much a problem of governance as a problem of accountability. In the end, who is accountable for the care? Who is accountable for the decisions that have been made? And it is not clear that this question has been answered. I have seen a lot of projects and pilots in which, yeah, you have clearly an intent to integrate patients in the decision-making process, but in the end, it's very difficult to know in the long term who will be accountable for the success or the failure of the experiment. Jason and I, we just have completed a systematic review of funding mechanism related to integrated care. And again, what is very striking when I look at the result of this is that there is a lot of things written about it. Very few of the models that are suggested as the best possible models for inciting integration in the health systems are actually used in Canada at this moment. And this is probably one of the area in which an agenda for change should, really invest both time and attention and multiplying interaction with decision makers to explain better why it is absolutely essential to address this particular dimension of integrated care in any projects. Most of the recommendations that are coming, and I know that there are experiments in bundled payments all over Canada. We have global budgets, but they are of another generation, and I haven't seen yet a lot of projects that are trying to integrate into global budgets the complete scope of integrated services that we're seeing in some experiments, particularly in the US. I really, my own conclusion of that, the 2 years we spent on this review has been clearly the need to build a proper Canadian research agenda on this question and starting addressing this as a priority for change. Delivery, so of course, you know, teamwork, as I mentioned, is as ancient as integrated care as a topic for research. The problem that we're facing here, or the lack of clear answers in this area, are for me mostly related. I mentioned decision making, but they are essentially related to the question of how do you keep people interested in this project? And you keep them when you address the question of incentives and compensation properly. I have seen interviews, I have been part of conversation where, you know, some categories of health providers are complaining that their time is less valued clearly than the time of others. And it creates problems when you try to build those teams and have them interested in those new models for care. And finally, maybe my last you know, series of observation on the literature is, you know, is it worth doing? So the overall answer is yes, for sure. And I will mention a few reasons where I think that we have learned through the last 3 decades a lot about the reason why this is worth doing. The first is for me is I called it here consistency of care, and it is very important because I don't believe we could achieve excellence in care without consistency. And the very important thing with integrated care is that it forces us to ask ourselves what exactly should we provide, how to avoid overuse, how to avoid inadequate care, and so on and so forth. And to do that in a consistent manner. And instead of the normal, but this is our system I've been built, the quasi-improvisation we're seeing all the time in healthcare organizations. And I think this is already a very important benefit of integrated care, bringing consistency to the care we provide. The second issue is clearly that integrated care will improve equity. I was struck in 2019 at this previous conference that I attended by data that are showing that are in our system, some people that are more vulnerable for all sorts of reasons that we know well, that are structural and systemic, those people are actually receive less care than they should. And in fact, integrated care is also a way to make sure that there is the offer of care, the access to care of those population is at the level where it should be, in a system that pretends that it is universal and that we provide as much as we can the same type and level of care to everyone. And integrated care, it's very clear. It's clear in measures that have been made here, and it's clear in measures that have been made in experiments in the United States, in the UK, in the Netherlands, always increase and benefit people that were underserved by the system previously. If only for this, we should be the champion of this approach. The savings are moderate. I had this Karen Davis, the former president of the Commonwealth Fund, when she went back to Hopkins, did a very careful study of Medicare patients, looking at what are the actual savings that are brought by the integration of their care. And I was struck by the numbers were very small. Was it worth doing? Of course, because even very small savings multiplied by the size of health budgets are big from a public perspective. But we shouldn't be doing it only for the money. The patient experience is in most time so much better that this as well is an incentive, I think, for us as health policy people to argue and advocate for integrated care. The other thing that I found very positive that is not mentioned enough, but you see that when you read carefully the literature, is that it is also a way, especially in a world in which there is a lot of constraints, budgetary constraints, regulatory constraints, and so on. Integrated care, it's very clear, create zones of clinical agency for the people that are on the team of providers. And I think also this is a very good benefit. Remember that one of the things with which I started at the beginning of this talk is this idea that the reason our reforms are not always sustainable is because they don't bring a difference both to providers and patient. And I think we could say that integrated care has been demonstrated to bring a better patient experience. It's very clear, but also is creating an experience that and resonates with the value of independence and agency that are so autonomy, sorry, and agency that are so important for clinicians. I would like to conclude. I already have went over my time, but I would like to conclude. This is a slide I presented in 2019. It's something that I call the Canadian consensus, and this is what I believe is what we have learned and that what we have tried to advocate in terms of changes in our system for a very, very long time. And I think that it will be still relevant post-COVID, that we continue to advocate for those changes and that we try as much as possible to work together to achieve this kind of transformation in our health system. The first thing, of course, is a strong primary healthcare system. There is a huge consensus that exists for, again, 30 or 40 years that we need to change the ratio between acute care and primary care. And integrated care, especially when it involves the community, I think could be a large part of what is called a strong primary healthcare system. We need to extend the range of services and goods that are covered by our system. It includes things that are very evident for everyone, like pharmacare and mental health. But again, when you start thinking about integrated care, you start thinking about how do I integrate in my system? This is the work I mentioned from the student of mine working on chronic kidney disease. What are the other services? What are the other goods that needs to be covered and completely integrated and I think this is a very important part of our agenda. And again, I think integrated care could be a part of this. Effective care teams, I mentioned that, I don't need to go back. The need for established pathways and a much better understanding of what are the pathways that a patient must follow to have consistent quality care. And again, this is something for which, basically integrated care has been built around this idea. Shared decision-making, I mentioned. As I said, the need to have a system that is not necessarily data-driven, but it's clearly data-informed, and so therefore in which access to data is much easier. It's in this ultimate goal of transparency that I mentioned. And finally, what we call outcomes-driven investments, which is constantly asking ourselves where to put the marginal dollar. From year to year, you have those slight increases in health budgets. You have this more public money going into our system. We have to ask ourselves more systematically where we could have the best outcome for the money we are investing in our system. I thank you for your patience and for your attention, and I look forward to our conversation. Thank you so very much. Jason?
Yes, I'd like to thank you very much, Dr. Faure. That was wonderful to kick us off this morning with the content. I'd just like to take this opportunity to remind all conference attendees to pose their questions on the Slido platform. And the conference access is hashtag CHSPR 2021. So after we hear from both respondents, we'll move over to the questions that have been posed on Slido. And conference attendees can vote those questions up or down, and we will work our way through those questions then. So at this point in time, I'd like to hand it off to our first respondent to PG's talk, and that is Elder Roberta Price. So thank you very much.
Sorry. My warm apologies, Jason. I could not, when I tried to put the chat down, I made myself disappear and then I couldn't put the mute off. So, warm apologies. Thank you so much for your presentation. I feel very uplifted on all the things that you addressed. I just want to move to I was scribbling down some notes there, and I want to move to what's most important to me on the outcomes is equity and patient experience. And I love that you mentioned about politics, because that's what I feel affects our healthcare system is politics. And which affects our patient experience, affects funding, all of those things. That if we could move to putting the priority on patient experience and equity and move those dollars around to address that, I feel it would be very, would change a lot of things and take care. And I really believe that the COVID really showed the inequity of what was happening in healthcare. For example, like, I don't know the true facts, but I believe it was a political decision to contract out for taking care of our most vulnerable, our people living in long-term care. And because they contracted that out, and it wasn't a dedicated funding to take care of our beautiful people in the long-term care places, is we've lost quite a lot of them. If it was fully funded and taken care of, many people wouldn't have had to take 2 and 3 jobs, and therefore the spread of the virus. You know, I think that that is my take on politics. And on the outcomes of equity and patient experience, as elder who has gone into the hospitals for more than 8 years, BC Women's, I've seen more than 4,000 families. In the other hospitals under Vancouver Coastal Health and Vancouver Providence Healthcare, I've seen close to 3,000 families. And what I really feel is, and I've said that, I've been an advisory as a parent and grandparent in the school system, in education. And what I say, we've been saying this for more than 40 years now, is that what we need to do is see ourselves reflected in the wards, in being taken care of by the doctor, being taken care of by the specialist. That equity goes in so many places, that we need to have more for Indigenous people, more Indigenous doctors, nurses, specialty folks, people working in the wards. We need to see more of that. We need to see ourselves reflected. And so that would help bring down the costs. And around the specialty care, going back to the beginning of your speech, your presentation, I really felt that, you know, as a person who's seen hundreds of families now transferred down from the north to the larger city, we need to move the funding to those rural areas. We need for specialist care, so that those folks don't get transferred away from their loved ones, often alone, often maybe allowed one family member or friend to support them coming way down here. So that affects their all around health. So we need to move to also a more holistic way of being with the patient. We need the decision-making of the patient and the person or the team, that it be all involved. Not, I know what's wrong with you, I can fix that. No, it needs to be reciprocal. It needs the patient and the specialist or the doctor or the nurse, they need to be together in that journey. So the equity goes right from the top on down. I feel that if we have equity, we see many of the different populations, not just Indigenous populations, but many of the different populations within Canada see themselves reflected in the care that they're receiving, I feel that it would bring better health on the health journey. And I just really want to thank you. I have quite a lot, probably a lot to say, and I hope I didn't sound too confused. Zoom is so frustrating. Things like being unmute, mute, showing your photo, like all of that. So I really, really want to thank you, and I hope that I haven't been too confusing, but I really, really appreciate what you have presented this morning, and that we have much, much work to do in going forward to make those changes so that it is, the patient is really respected and reflected. OCM, thank you.
Well, thank you very much, Elder Roberta Price. I think we can all, every single one of us, share your frustrations with Zoom. It's just something we live with now. And I would just like to remind everyone to move over to the Slido page as well, and enter and/or vote up the questions that you see there throughout the discussion this morning. And with that, I'd like to move over to our second discussant and respondent, and that is Tess Romain, the CEO of the Toronto Central LHIN. So with that, over to you, Tess. Thank you very much.
Thank you so much. Thank you to PG4A and Elder Price and Jason. Thank you for allowing me the opportunity to be here, and happy International Women's Day. I also would start with saying, although that we're meeting virtually, I'm in the city of Toronto, which are the traditional territories of the Huron, Wendat, Anishinaabe, and Chippewa, the Haudenosaunee Confederacy, and most recently the Mississaugas of the Credit River First Nations. So when speaking to Sabrina about this, and I do want to respond, and my focus is really more on some specific examples, especially through learnings of COVID, but wanted to provide a bit of context about what the LHIN actually is. The Local Health Integration Networks, or LHINs, were created in Ontario through a Local Health Services Integration Act of 2006. And there were 14 LHINs established across Ontario, and we are accountable for overseeing planning, funding, and integration of local health services like hospitals, community support services, home care, mental health and addictions, long-term care, and community health centers. I will note that these health service providers do maintain their individual boards, and we aren't, funding for primary care is still maintained through the government through OHIP funding and the direct accountability. And as I speak today, the LHINs are going through a transformation. So as we talk about integration and transformation, we're actually part of a transformation underway right now into a new Crown agency called Ontario Health, of which 20 agencies are being integrated into that organization. So although I am the CEO of the Toronto Central LHIN, I'm also the cross-appointed as the regional lead for Ontario Health Toronto region. And you'll hear me speak about region or LHINs interchangeably. So the 14 LHINs will now be, have now been sort of organized into 5 regions across Ontario. In Toronto, I think we most know it's a 4th largest city in North America, a very diverse population, about 1.2 million people. Our LHIN doesn't cover the entire city of Toronto, but a big part of it. And just a bit of context in our journey, because since starting with the LHIN and in 2016, really we recognized the LHINs had always had an accountability for integration, and wanting to leverage the learnings over the last 10 years of integrations, which I think reflect very much what PG had said about different pilots and different ways of doing that, is that we really wanted to focus more on the sub-region or hyper-local areas. So focused more on geography to help organize integrations. And in doing so, really brought local teams together, which were constituted hospitals and community and primary care in a defined geography, to really understand their population and be able to understand not just from a quantitative and data analysis, but we also work to try to provide qualitative data. And not unsurprisingly, many folks didn't necessarily know all of the service providers that were even within their own geography, and had not, and although they had potentially had some integrated programs that were working together, and there had been great successes, I think, in the past in terms of health links and other pieces that might have been focused on specific disease or pathway or groupings, actually coming together, people were able to learn a lot more about what other service providers were in the area and start looking at it from a population health and equity approach. We've been through many iterations just in the last few years. In 2017, the LINs actually merged with the 14 community care access centers, which were responsible for providing home care in the province. And through this work in Toronto, we've been working to really integrate home care with our view of system planning and system oversight. And in 2019, the Ontario government announced the creation of Ontario Health Teams, or OATs, as they are sometimes affectionately known. And really the vision of OATs is to better connect different parts of the healthcare system by bringing together as one team, patients, families, communities, providers, and system leaders to deliver more coordinated care for people in a defined geographic area. So our work that had been underway to build 5 sub-regions in Toronto really nicely connected to the future state of an Ontario Health Team. And so all of our 5 sub-regions are now Ontario Health Teams in Toronto. I wanted to speak a little bit more about examples from COVID. And when COVID hit Toronto, we had the first COVID positive case in Canada was in Toronto on January 25th, 2020. Our regional response in coordination with the provincial government and public health and Ontario Health actually depended very heavily on these local subregions, or OHTs. Our key focus quickly became, and it was very evident, and I think this is what Elder Price just referenced, is the need to focus on equity at the local or neighborhood level. We saw that the data was telling us that the rates of positivity were disproportionately impacting racialized, low-income, and vulnerable populations, and that there was a need to leverage and build on those who had trusted relationships within these communities. And I'll speak a little bit about our specific example in testing that I think for me spoke to the connection between government and policy through to local teams working together. Really what we saw in the testing example was that the province set out the expectations related to COVID testing, including securing the resources required to develop the coordinated and comprehensive testing approach. And then working through the relatively new Ontario Health Agency, a provincial integrated lab system was established in record time. And then through regions, we worked with health service providers who collaborated to set up, staff, and run testing sites across our 5 regions. Across the 5 regions of Ontario, including Toronto. And so quickly we saw the need to establish a cross-sectoral Toronto COVID planning and response table. And this was a bit interesting because although we had done a lot of work and had a number of tables, many iterations over the past number of years, being able to bring a group together that represented different sectors, primary care, public health, acute care, and others, people came together. Obviously, it was also a crisis, but came together and we had good different perspectives to really monitor the overall response. And that included looking at the positivity rates. So as COVID rates continue to rise, it was evident that although the testing demand overall in Ontario was high at an aggregate level, even in the region, you could see that there was a great demand for testing, that rates of testing were lower in what was considered high needs communities. So those with low income, racialized, or vulnerable population, and where the positivity rates were disproportionately higher. Through the Ontario Health Teams, those local partnerships, health partners began to reach out to those with trusted relationships in these impacted communities, including primary care providers were key partners in this, and both health and non-health community agencies. These groups then developed pop-up testing proposals and ideas and plans for pop-up testing and mobile testing sites. They actually engaged and connected with the public health clinical experts to respond to questions and bring information to people in the way they needed to understand the information and address the fears and mistrust and misinformation about testing that were prevalent, as well as connecting even to the extent of schools and our education system to be able to support parents in a lot of information that they needed that they might not necessarily have been able to understand because there were multiple sources of information. These teams identified key barriers to testing, which also required government intervention, like eviction moratoriums or sick pay, and partnered with local non-health funded community agencies like United Way funded agencies and City of Toronto funded agencies to provide services such as food security, housing supports, employment, and other similar services that really met the broader social needs, which I think was one of the comments reflected earlier for those who were impacted. The region, so our role as a region was being able to work between the provincial government and these local teams to share this feedback and work together to be able to develop policies and programs at the provincial level that responded to these to this feedback. And I think there were some good examples, such as funding for high priority neighborhoods, which was a program that was developed and implemented to be able to improve and increase testing rates, and provided the flexibility required at the local level to support implementation. As well, we had a great partnership between Anishinaabe Health Toronto, who launched their mobile healing RV to bring testing and healthcare services to those who were homeless and encampments, and are now leading vaccination efforts for our urban Indigenous community, for the urban Indigenous community in Toronto. And this was a partnership with Women's College Hospital and other community health centers, in which they respected and followed the guidance of Anishinaabe and how to implement this program and really work towards bringing their services together. As well, there was a team established a COVID recovery hotel that provides an isolation center for shelter clients. And again, this was a partnership between the City of Toronto, Public Health, Hospital, Community Health Centers, Inner City Health Associates, which is a primary group dedicated to the homeless population, and many other community partners. And that it offered not only space for isolation, but harm reduction, as well as mental health supports. So really recognizing the holistic needs of the population and being able to come together in order to address this. And this combined community approach really leveraged a backbone of infrastructure in the hospital as well, in infection prevention and control, PPE, and really the key medical expertise of each of the inner city health associates as a primary care and medical expertise for the group. So really, I think, you know, we've seen through COVID local teams responding in an integrated fashion because no one provider or organization could take this on alone. Partners depended on each other, and they needed the experience and expertise of different parts of the health and non-health system in order to respond to what they were seeing at their front door. So I think aligned with what we've heard, you know, when I look at our experience on the more closer to the ground through COVID, I think we saw that although COVID lay bare some of the challenges that we all know exist in the healthcare system, it also was interesting in really advancing what we had been working on and talking about in terms of integration in a way I think we hadn't seen. The ability for the local teams to collaborate and identify barriers and really develop local solutions that met the needs of those they served. I think for the region, being able to coordinate some of this work, share the learnings, but also to the point of accountability, being able to create dashboards and share data that enable people to be accountable and held them accountable for the initiatives that they implemented while providing funding that was flexible and allowed teams to be able to do what they needed to do to meet their local population, but also ensuring, I think to an earlier point, is that there was consistency across. So through the regions, we all coordinated with Ontario Health at the provincial level and with the government to ensure that there was overall a sense of where we were going, that we were following government direction, that we could also provide feedback to government that would allow them to be able to develop legislation or policy or regulatory framework or tools as needed. So really, I think key parts of what I take away from this particular experience that we are still in is that really that we have the building blocks, as was noted, for integration, and especially at the local level, people do work together in many different ways. I think, of course, that having a crisis like a pandemic created the urgency that we all know often is part of fundamentals of change, but also the importance of recognizing trusted relationships, the relationships between a provider and their patient, between a community agency and those that they serve, faith leaders and other groups that came together to be able to respond to individuals' needs that encompass more than healthcare, and being able to understand what's happening on the ground and then be able to translate that and then understand how to enable policy or enable funding or programs that meet those needs. And I think those are key parts that I agree with the comments that were made. I think the patient, the community was a key part of this. It was about listening and then enabling our teams to come together to meet their needs in a way that was different into what we have seen before. And so I think that it's been a great opportunity to learn, to I think what I take away from this is sustaining the gains. We have to find the way to sustain the gains. We can't lose this. And it's important, I think, that we continue to make sure that we look at these local teams and how they come together, what worked, and how do we enable and I say we as part of government, as a Crown agency, enable this to happen at the front line to ensure that there's a way to continue this work that we can share and then continue to evolve and improve as we iterate. So thank you for the opportunity. Those are my insights and happy to speak further.
It's Jason here again. Thank you very much to both PG and Elder Roberta Price and Tess Romaine for responding to PG's talk today. The way this is going to work is that what we're going to be doing is reading off the highest voted questions that people have submitted to Slido. So I'll read those aloud so that we can get them on the recording. And I will, if the questions are directed to either the respondent or to Dr. Foray, read them to them specifically, but I think a lot of the questions are coming in more broadly. I'd also like to just note that the chat function of Zoom is being monitored for technical issues as well. So if you're having technical problems, please put them in the chat box if you are able to. So I think we'll start off. And I think that this question is probably, open to all three people from our first session, and maybe also provide some context or environment which provides you, the path of how you arrived at your definition. But the first question here that a lot of people voted up was, how would you define integrated care in one sentence? So I think we'll start off with Dr. Foray, and then Elder Roberta Price, and then Tess Romaine, if you'd like to give an answer how you define integrated care.
Jason, you want me to start? I have no way of doing this. I think what I've tried to show is that at this moment, we're facing a menu of, literally a menu of choices between options on funding, on scope, on the way care is provided, et cetera, et cetera. So it is very difficult. I've seen reports, very serious reports that starts with 3, 4, 5 different definitions. And they conclude, well, it's impossible to really define integrated care because, et cetera. And I think this is the problem we face. We could describe what integrated care for a given clientele will be, what for a different place will be, in a particular context will be. But I think we're losing our time trying constantly, again, because there is no real consensus. We have a sense of the overall destination, but I don't think we have a sense exactly of what we want to do because we are trying to solve very different problems.
Okay, thank you very much for that, Dr. Foray. Elder Roberta Price, would you like to have a crack at that one?
Yes, to define integrated care would be respect, reciprocity, equity, and moving away from politically affected shared decision-making. Like I said before, that shared decision-making with the patient at the best of their ability, with the professionals that are there to take care of them. So remove politics. OCM.
Thank you very much. Tess, Romain?
Well, thank you. And I agree with Dr. Foray. This is a difficult one and something I feel like I've spent many years on as well. I couldn't agree more, Elder Price, in terms of it being centered around the patient, the person, and what their definition of integrated care means. I think often I hear about the problems and the challenges of actually integrated care, and those often come in difficulty in navigating the system, you know, inability to access, not understanding communication, or lack of communication. And I think that if I reverse those from what we hear often is that integrated care probably encompasses those pieces: better access, better navigation, and better communication. Although the way to get there is so complex, I think it would be difficult to answer in one sentence, because it is about a number of different elements that need to come together in order to achieve that, both at the patient or person level and the provider. That wasn't one sentence, I apologize.
Well, I think it was a tough concept to get through in one sentence. Okay, we're going to move to our next question. And I think Dr. Foray uniquely has experience both working at federal and provincial levels to be able to address this, but I would encourage our respondents to also join in. So the question is, do you have any comments on the potential role of the federal government for interprovincial territorial collaboration on implementing integrated care? Dr. Foray.
First of all, with my brilliant colleague Danielle Martin from Women's College 2 years ago, we wrote a report in which we spoke about the need to increase capacity at federal level to achieve exactly these kind of outcomes and results. So overall, philosophically, I think there is a role for the feds to play other than just sending money to the provinces. But the role can be only in facilitating communication and learning between provinces and territories about what they are trying to achieve. As I said, one of the things I have always found very strange in this country, when you travel from coast to coast to coast, that nothing's looks more like a Canadian hospital than another Canadian hospital. What André Picard keeps saying, that the guy who sells them the paint, the green paint that they put on their wall, must be very rich. And in part, our system is much more similar than people imagine. And each time I'm in a provincial capital and I'm discussing with health authority, they are telling me, oh, as I said, it's so different here. We cannot replicate what Ontario just did, or we cannot replicate what Quebec does, and so on. And I think this is an issue that it's not so much an issue of political will, that an issue of facilitating learning and conversation. And each time we have built institutions that we're trying to do these kind of things, we have not very, very good at supporting them. And I'm thinking, of course, of the Health Council here.
Okay, would anyone, Tess or Roberta like to take a crack at this one? Okay, Roberta.
Again, it's the winds of political will that affect true collaboration on a federal government or interprovincial territorial collaboration. It's the politics, I say, that affects. And I think there's more will on money-saving initiatives rather than looking at what really can help people to become well. And again, I say, if we just took healthcare out of politics and did what helps people to become well, people really will become well in this country. OCM, thank you.
Okay, well, thank you very much. I suppose we'll move right along to the next question. This one is directed specifically at Dr. Foray. It says, PG, you note that the government won't take risks with pilot projects. What do you think could be done to get them to do so?
Well, I'm not so sure that I think this is something I said many years ago. I don't make friends when I say that, but I think we're as guilty as governments. And, you know, also we like to see our projects funded. We like to be able to publish, and we tend also to limit risk when we start developing and looking for support for a project. I have seen, you know, many of the pilots we have conducted. Again, they were successful, of course, because they were, as I said so many times, they were designed not to fail. And when you design something, you have to introduce so many constraints in your model that in the end, it's very difficult to replicate. We have to accept more risk. We have to accept more risk in the way we conduct our experiment in our studies. I think we shouldn't be I refuse to put all the blames on governments. You know, it is also part of our responsibility. And I'm talking essentially as a health researcher, also to be thinking on how do I design what I'm doing so that it has a chance to be replicated, that it has a chance to actually be something from which I could really learn, instead of just being a brilliant, like, you know, the model house you're saying when you're visiting a new development. Of course it's perfect, you know, and this is what we tend to build in our own projects.
Okay, we have quite a good number of questions here, so I think I'll just move along to the next question. It's a little confusing here because the next one has 7 thumbs up versus 13, but I'll read from the top, the blue one. This one is directed at Tessa Romain specifically. Can you please talk about creating OHTs in rural and sparsely populated areas? How is it different from urban Ontario?
Thanks for the question. And we'll note that being the regional leader and CEO for Toronto, it's quite focused urban from an urban perspective. But I will say that in working with my colleagues and across the province, I would say that one of the key learnings is that OHTs that are being created in urban areas definitely have more primary care community leadership. So I think in an urban environment, one of the things that we've seen often is the acute leaders, the hospital leaders, those larger institutions play a larger role in the Ontario Health Team development. Whereas if you go outside of Toronto into certain areas, you see a lot more focus and leadership from primary care community partners coming together as well. I think, you know, geography does sometimes make a difference. If you have a large geography and a smaller population, the types of challenges that the patients or communities face make the solutions different. But I'd say that actually I think there's been some great examples of OHTs that are being created in Ontario that are in rural and different areas, rural and sparsely populated areas that are working quite well. Obviously, one of the big differences in an urban environment is sometimes the dense population that we actually have. And although you would think because there's a number of providers and folks that might be able to reach people, it can actually be quite competitive. And following Dr. Fauré's comment, it's actually quite a competitive environment often where groups will want to come together and start a pilot or have an idea of how to address a certain population or a disease or a specific group. And then it becomes a matter of funding a number. So you have a number of flowers blooming that unfortunately you don't necessarily see always how these can come together. But those would be my comments. I think that there are very different opportunities, but it's working quite well. And I think that you just have different leaders coming together to find solutions in those different areas.
Well, thank you very much. That was great. Now we're going to move to our next question. And I suppose this is open to all, and that is, how do you view virtual care in relation to integrated care? So maybe we'll start with Elder Roberta Price. Would you like to take a crack at that?
Yes, although it's so hard to be on Zoom and really very, very different in relations to my care. Because of COVID, they moved me, that I wasn't allowed to go into all the hospitals like I did. So we moved to virtual care through either telephone for the patient to access me as an elder, and or Zoom if that ability was to set up. So I think that this would create more opportunities for integrated care, because then, you know, the ability of the specialist or whoever was needed for the care of the patient would have to like travel. And I think to do things virtually might be a benefit to integrated care, and have great hopes for that. OCM, thank you.
Thank you. Tess, on the ground with the delivery system adapting, would you like to take a crack at that?
Sure. So I see virtual care as it's been both an enabler and in some ways a barrier. So it's mostly an enabler. So I would say through, and again, I'll use the experience of COVID having been the most recent, but because honestly, virtual care has just exploded and changed through this pandemic. But it's been an enabler, and obviously in the ways that Elder Price spoke to, but also in examples like in long-term care, where you'd potentially, there was a long-term care plus project where in Toronto that was launched, where and across Ontario, where you know, long-term care staff were able to access specialists or geriatricians or others utilizing the virtual technology when we know that it was difficult for people to move in and out of those facilities. That's a good example of, I think, where virtual care has really worked well, and there's many, many more. On the other side, there's also been an issue of equity that I think has come up very clearly. And so although you have virtual care, there's, you know, and we're getting into the data now, and I'm sure there will be many reports and reviews on this, is what has been the disparity or the impact on those who haven't been able to access certain care because they weren't able to access it virtually. But I do see it as an enabler. It's a key part of the Ontario government strategy in terms of supporting Ontario health teams, digital and virtual. And we've seen, I think, some great examples, even to another example that comes to mind is COVID at home, where people have been able to be remotely monitored post-discharge from the hospital, their oxygenation levels. And that's a great example, again, of how virtual fits into an integrated care team as an enabler to allow more people to be involved in that particular patient's care, which is quite positive.
All right, wonderful. Dr. Faure?
Just briefly, because I think what Roberta and Tess said are totally right. I'm like most people, I have been struck by the speed at which the system has been able to pivot, you know, during COVID. You know, things that were strictly impossible became possible in 10 days. And I think this is a very interesting part of the last year. You know, we have seen so many obstacles disappear due to the pressure created by the pandemic. Where I am, you know, I think what Tess said is very important, is that it played a very important role and got integrated relatively smoothly in the healthcare part of integrated care. The part that is not well supported by virtual relationships is the social part of integrated care. And here, I don't know, you know, I think that if we're just thinking narrowly, you know, a relatively traditional model of integration in which the problem is just, could we discharge you faster? Could we send you back to your home and so on? Yes, progress and movement. But on the other hand, what we have learned in the last 20 years is that so many dimensions that we want to integrate in our general approach are part of spheres that are very, very difficult to connect through Zoom, through the phone, and so on, that require direct intervention, presence of a social worker in the home, and so on. And all this has been made very, very difficult, and there is no substitute on the screen for this. And this is something, so again, you know, major gains, many obstacles that we were told were, you know, impossible to ignore suddenly have disappeared. But on the other hand, I have seen a certain level of shrinking of, and as Tess knows better than I do, a large part of the advocacy work in Toronto has been to keep these models stretched so that we could actually address the full spectrum of problems created by vulnerabilities, status of racialized populations, and so on and so forth. That requires other things that virtual connections.
Okay, well, thanks to all three respondents to that question. We'll now move to the next top voted question, and that is, which outcomes, for example, population health, patient or provider satisfaction, etc., are you referring to when you talk about outcome-driven investments? Now, PG, this was taken from one of your slides, so maybe you could start off with addressing this question.
Yeah, we created this particular label to describe a way of thinking about the marginal investment in health and social care and asking ourselves, how do we produce the best outcomes in terms of population wellness? And the idea that, we have now demonstration for this for Europe, for the United States, and through our team at the University of Calgary for Canada, we have shown very clearly that investing in social policy, investing in social programs, investing in education is clearly a better way of investing your marginal dollars than investing them in providing a new MRI in a rural area. And and what we call outcome-driven investment is thinking all the time about the outcomes that we are trying to achieve. And we could show that, again, we're talking about the way government is defining those programs when they do the health budget at the end of the year, and they're trying to think about the marginal increase in spending, how to make sure that we're putting our dollars at the best place. And this is not new knowledge. This is something we know for 50 years, but I think we're trying now to show it at a relatively at the level of granularity where it's possible to actually make decisions. It's not only a question of philosophy, it's a question of properly investing public money.
Okay, well, thank you very much for that question. I think we will have time for one more question, and that is probably best spoken to by all three. So what are appropriate measures of system integration and networking in primary care? How do we know when we're more or better integrated than before? So I'd like to start off with Tess Romain with this one, and then we'll move to Roberta Price if you have a comment.
Well, thank you. This one is, I feel like this one isn't often discussed, and I wish I had a great answer for this. Because this one has been going back and forth for, I know, as long as I've been in healthcare. What is the appropriate measure? I think when, again, I come back to, as I break it down, sort of what does it mean if we have an integrated system in primary care? And it means that people are attached. It means people can get access to their primary care provider. It means that they're happy with the services typically. And I think as we think about what are the appropriate measures, obviously there's ones that are typically easier and tend to be the ones of focus of government or regions and health authorities, which is, attachment rates for people to primary care. Again, on that one, I always just highlight that things like that are great at an aggregate level, but when you say 97% connected and you figure out what the 3% is, oftentimes those are people that are the hardest to connect and the ones who utilize the system most. So I think there's an important piece of that always has to be considered. I think referring to people being referred to screening, or if with diabetes, certain measures to that are often used. But I do think that the satisfaction, the number of times people, the ability of people to access their primary care providers, those are the measures that I think are important and demonstrate that there is integrated care and people are being able to access the services they need beyond just primary care, as well as primary care being really hearing from them. Are they able to access for their client patients the services they need? And I think that is a difficult measure to come up with. other than asking your typical sort of prems and proms and asking people of their satisfaction rate. But I'd say the ability to get people, for example, into a specialist service or access to a service as quickly as possible, or getting them into home care or having their services met and not having to have as many visits, could also be seen as a system measure that primary care is actually networked and working within the system. So I wish I had a great answer for this, but I think it's one that many struggle with all the time and are continually iterating in terms of what the measure is.
Well, thank you very much. Elder Roberta Price, would you also like to weigh in on this one?
Yes, thank you so much. Thank you, Tess and Dr. Foray, for everything this morning. And I just want to share with everyone that I always just speak from my own experience and use myself as an example. And what are appropriate measures of system integration and networking in primary care? I would say lives saved, patient satisfaction, more people being well in this country, right across every single province and territory. How do we know when we're more or better integrated than before? Like what I speak about all the time is that, you know, in the schools of education and training, that we begin and have begun in many areas to decolonize the process, look at different ways of knowing, and especially of the first peoples of this country, Indigenous ways of knowing and doing. I really feel that changing policies on how to get into those schools of training and education, policies around job descriptions and role descriptions, and how we welcome more people to show that reflection that I've been speaking about within those hospital rooms, within the hospital wards, within the clinics, everything. To show that reflection, we need to make all of those changes right from the top on down. So that's when we'll know we're more or better integrated than before, when we see ourselves reflected in all of those areas from any population that is here in this country we call Canada. OCM, thank you. Thank you. I hope that answers.
Thank you very much. And to conclude this session, Dr. Foray, would you like to have a say about the last question?
So the first thing, I subscribe to all that Tess and Roberta said. You know, I think they really covered the ground. I'll end by, this is an indirect answer, but I think you will see where I'm going. A project that I started when I was at Hopkins with a group of people there. And our initial questions was how to integrate information so that a clinical encounter, whatever it is, social worker, primary care doc, nurse practitioner, etc., at the point of clinical encounter, the client or patient or user and the clinician will have a full understanding of the context of that particular user or patient, which is easier to say than to do. You know, it requires an integration of information coming from the structural situation of the person, the biology, from its environment, and so on. And it's again, it's quite difficult to do in practice, but this is one of the objectives. But midway to the development of this project, we realized that this is not enough. We need to understand that in this encounter, we need also a way to act on the community in which this person is embedded. And working on those two dimensions for me are the real measure of success of integration. In a way, this is what I'm trying, and that we would like try to measure, is that it's not enough to fix your knee issue. It's also important to have a sense of the community as a whole. And I think this is for me, a very important lesson of my again, at my very humble level, at working with people that are trying to build those tools. And I think the next generation of measurement will try to capture that, the health of the community at the same time you're measuring the health of an individual user or patient.
Okay, thank you very much. This concludes the first session of the 2021 CHSPR conference. Just as a quick update, we will be having a short break now and reconvening at 10:40 sharp for our second session entitled Integration of Care, what do we know? So with that, I'd like to say thank you to everyone for participating and posing their questions in Slido and voting on Slido. So for Elder Roberta Price, Tess Romain, and PG4A, thank you very much for sharing your time and your experience and knowledge with us. Thank you very much.